Alrighty, everybody, welcome back to the EKG of the week. Today's EKG, let's go and get started. So first thing I do is I'm going to go through, kind of look at the forest, look at the trees. We'll look at lead 2 here at the rhythm strip. We'll just look at our QRSs. Ticking away here, not the fastest rate. Seems to be pretty regular. Kind of got this early looking beat. And then we get back on our regularity. I see I have some type of narrow QRS here. There appears to be some P waves. So, okay, that's a good start. So let's figure out what the atria is doing here in our rhythm. And if I look here at lead 1, I see some flatter P waves. They're difficult to see, but I can see that this correlates nicely with this P wave in lead 2. My P waves appear to be upright in AVF, upright in lead 1. So this is a sinus P wave, which is important to delineate. And so now I'm going to go through my conduction system and evaluate the AV node in the form of the PR interval. My PR interval appears to be long. If I look here, it's just greater than 200 milliseconds. So it tells me there's maybe an AV block of some sort. And let's figure out what that AV block looks like. And if you notice, as we evaluate sequential PR intervals, we'll take a look and we'll see I've actually got these P waves that are, you can see almost a P wave kind of buried in there that seem to be occurring without a QRS. And the PR intervals, if you look at this one, is very long compared to this very short PR interval. So this makes me think maybe this isn't just a simple first degree AV block. Maybe this is a higher degree block. And so how would I determine that? Well, let's take a look at this beat here that we said was funky. And so what I see is I have P, QRS, with a PR interval that is roughly 200 milliseconds. Then we have another P conducting to a QRS, but that PR interval gets longer. That PR interval is maybe 300 milliseconds. And then what you'll notice is the next P wave, if you look just right there, there's a little notching on the T wave that likely represents a P wave that is superimposed on that T wave. And you can always compare the previous T waves where you have a nice smooth T wave, very smooth, very smooth. So always compare to previous T waves. And so my PR interval is lengthening and lengthening until it drops. And so this is a second degree type 1 or a Mobitz 1 or Winky-Bach AV block. And so the AV block, though, sometimes it'll conduct once and then it'll block. Other times it'll conduct, and then block. So this Mobitz 1 is, sometimes it is a conducting in a 2-to-1 fashion, meaning that you have 2 P waves for 1 QRS. And then in this group, there's conducting in a 3-to-1 fashion. So there's a variable conduction in this, using 3-to-2. So there's variable conduction. So, okay, so that's our AV node function. Let's continue down and let's look at our QRSs. Our QRSs we said are narrow. I'll use red here and just make sure QRS is narrow, less than 120 milliseconds. Our QRS axis is upright in 1. It's upright in AVF, so I know it's going down to the left, so it's at normal axis. Let's check our ST and T waves. And if you see, if we scan through, we've got this T wave inversion with some depression in lead 1, depression in AVL. We've got some elevation in our inferior leads, which are 2, 3, and AVF. We've got our baseline here. We've got a few millimeters of elevation. And that in the setting of reciprocal depression in our high lateral leads in 1 and AVL, we would say this is an inferior ST elevation, which suggests inferior ischemia or infarction. And so that's our EKG evaluation. So this is a sinus rhythm with a second degree type 1 or Movitz 1 AV block, as well as inferior ST elevation. And likely this person's AV block could be due to some of this ischemia. So I would love to see what this previous EKG looked like and determine is some of this ischemia that is affecting the inferior leads also affecting the AV node, because we have this AV block, and we know that the SA and AV node are supplied by the right coronary arteries, and the right coronary arteries also supply some of the inferior aspects of the myocardium. So clinical correlation here, we might be affecting the AV node with some of this ischemia. So hope that helps.